Okay, thank you, Steve. Well, it looks like we have representatives from most of the major media outlets, as far as I can tell by name, in our participant list. So with that, we'll go ahead and get started here, everyone. So to our media friends, we're going to go ahead and begin. Good morning, everyone. My name is Dara Demai, and I'm the Communications Director for Wake County Government, and I'll be serving as your moderator today. I want to thank the media for joining us this morning. We appreciate you helping us share some important information with the community about the impact of COVID-19 on our local healthcare system, which includes our hospitals as well as our EMS system. Today, you're going to hear from Dr. Timothy Plonk, Emergency Department Medical Director at Duke Raleigh Hospital, Dr. Linda Butler, Chief Medical Officer at UNC Rex Healthcare, Dr. Seth Brody, Chief Physician Executive at WakeMed Health and Hospitals, Dr. Micah Krempasky, Chief Medical Officer at WakeMed Behavioral Health, and Dr. Jose Cabañas, Chief Medical Officer for Wake County. After they make some brief remarks, I'll open the floor up to questions from the media. At that time, if you could please type your name, the name of your media outlet, and your question into the chat box, that would be great. And then I'll answer them in the order in which they're received. So with those directions, let's go ahead and get started this morning. Dr. Timothy Plonk with Duke Raleigh Hospital is our first speaker. Dr. Plonk?
Yeah, thanks for the opportunity to speak to the group here. I'm Tim Plonk, and I'm the medical director for Duke Raleigh Hospital's emergency department. I'd like to begin by saying it's an honor to have been on the front lines of this pandemic, working with a fantastic group of people for the past 18 months. This past year has presented incredible challenges for our hospital, our providers, nurses, emergency services, and to our community. It's hard not to be a little bit disappointed at this point with our current position. We've had a lot of successes, but just as we felt like there was some light at the end of the tunnel, over the past several weeks, we seem to be thrust back into another wave of this pandemic. What we're seeing in our emergency department is not just COVID cases rising. It's also sort of the effects of an 18-month-long pandemic that we're seeing. It's folks who have chronic conditions who haven't been able to care for themselves as well as they might have been otherwise. We're seeing folks who've lost their job, who've lost their insurance, who've had changes in their family situation, who maybe have lost folks in their family, who may have been primary caregivers, or had changes to their primary care. All of these things have created gaps in people's resources that would otherwise keep them healthy. Compounding all this, I think we see a county that is one of the fastest growing counties in the region, giving us a lot more people in general to care for. What this all means for us in the emergency department as this new wave hits is that we're busier. Our patients are a little sicker, oftentimes very sick, and our staff is working harder, and our lobbies are full. Our wait times are higher than they've ever been at Duke Raleigh. I'm sure that other hospitals can agree to that as well. And it's creating a great deal of stress and frustration, a very understandable frustration. I think a lot of people are waiting in our lobby and in other lobbies around the country longer than they ever thought they would have to wait for healthcare in this country. But like I said, we're not alone in this. I think this is a county thing. I think this is a triangle thing. I think this is a state thing. And I think this is a problem facing our country. I would like to say, though, that even before COVID, our hospital and our hospital system regularly hit capacity levels during seasonal surges. And we have a great team of people who are experts in managing these high volume times. This COVID surge adds a magnitude of pressure, though. And I'd like to be the first on this group of people to recommend that folks out there in the community get vaccinated. our ability to care for all the patients who need care, COVID and non-COVID, is very dependent on our community's ability to help stop the spread of this virus. I look forward to working with everybody here on this conference, as well as in the county and in the region, in whatever way we can, to work together as a team to get through this surge. That's all I had to say in my statement.
Great. Thank you, Dr. Plonk. And can you speak to the concern that people might delay or potentially not seek medical treatment at all because they're not sure where to go right now, and maybe they don't even think their condition warrants medical attention?
Well, so the last thing that I would want to do would be to discourage anyone from seeking care. I think there are a lot of options out there. The first, as an emergency medicine doctor, the ED is open 24/7. We see people for all kinds of things and for all kinds of reasons, and we're happy to do so. That's why we're here. There are other options though, and I think it's important to familiarize yourself as a community member with those options, and use your best judgment. There are primary care doctors' offices, there are urgent cares, there are minute clinics, clinics in the pharmacy. There are a lot of people that you can connect to ask questions, and a lot of people out there who are happy to help you find the right place for you to seek care if you have questions about that.
Great, thank you so much, Dr. Plonk. Our next speaker this morning is Dr. Linda Butler with UNC Healthcare. Dr. Butler?
Hi, Dara, and good morning, everybody. Thank you for the opportunity to participate in the press conference. Just like WakeMed and Duke Raleigh, the UNC Rex has experienced extremely high volumes of patients. We have over 500 patients in our hospital today, I think 520, and we're a 439 bed hospital, if that helps you put it into perspective. Our ICU beds are full, and just as Dr. Plonk said, the acuity of the patients we are seeing has definitely increased through this pandemic. Part of our high patient census is due to some difficulty really transferring out and discharging our patients. There's a lack of skilled nursing bed availability, not just in Wake County, but throughout the state. We have difficulty finding placement for geriatric dementia patients. Assisted livings are challenged with their behavior, so they bring them to our emergency department and we end up caring for them in the hospital. We also have been faced with staffing challenges like all healthcare facilities or systems across the nation. There's a concern that even having a vaccine mandate at the end of September will have some staff choose to leave healthcare because they don't want to be vaccinated. But we know vaccinating is the right approach for our patients and our workforce and our community. Our clinicians have been caring for the community throughout the pandemic, and just like the team at Duke Raleigh, they are exhausted. They still continue to provide very high quality, safe care. And it's surprising to me that our patient satisfaction scores are still quite good when I know how hard our teams have had to work. In particular, the Delta variant has caused a higher proportion of the admitted COVID patients we're seeing to be placed in our ICU. So 40% of our COVID patients are in an ICU. And what is very worrisome is the predictive models we have for this surge shows that we'll have more patients hospitalized than we did in January and February. And we're going to have to care for those patients with less staff. And now with having higher ICU patients, that even adds an extra burden. So our ask from the community is, to seek care early and in the best place, and to turn it around slightly differently from what Dr. Plonk said. Early on, go see your PCP. Your primary care provider knows you better than anyone else. And if it's a problem that can be taken care of at an urgent care facility, they're typically open 7 days a week. They're not open 24/7 like the emergency department, but many have 8 to 12-hour days where they can see patients. And then finally, when you come to the ED, just be prepared to have a long wait, because we're so full in the hospital that when patients are admitted, sometimes we're holding patients in our emergency department for even up to a day. So there are several days during the week when our largest inpatient unit is actually our emergency department. So they're still seeing all of the other patients through a smaller number of beds or in non-traditional spaces. I believe last month or even this month, EMS had to wait for a couple of hours for a space to open up to leave a patient, and EMS has never had to wait in our ED before. So that's just speaks to the volume challenges that we have. And then just be patient with our staff. They are doing their absolute best, taking care of everybody. And we know no one wants to wait, but that's just the reality of our situation. And then my final plea is to urge everybody to get vaccinated. That's the most important thing you can do. And then while you're out in the community right now, even if you are vaccinated, please wear your mask and practice good hygiene, hand hygiene. So that ends my comments.
And in case the situation with COVID in our community, the surge we're seeing does get worse, what are some of the steps that UNC Rex might take to respond to that?
We've already returned to some of our previous surge processes that we had in the hospital. We have, our COVID debriefs. We've opened our command center back up Monday through Friday to help with collaboration. We're recruiting more staff, which we had been doing before the surge. And then we have decreased our elective or non-emergent surgery volumes to make sure we have beds available for patients coming in through our ED. We've not closed any beds for even with our staffing shortages, and we are looking at holding more patients in non-traditional spaces like our PACUs or procedural areas. We will also look at pulling some levers that we had earlier on, going to a team approach to care and expanding ICU beds beyond our current footprint into other units. We're actually having people who are coming out of retirement. We have a retired nurse working in our monoclonal antibody clinic. We've ramped that up to try and get more patients into that clinic to prevent admission. And we're also going to look at people who are in administrative roles who were clinicians in the past to come be extra hands on our units. So those are just some of the things that we're preparing for.
Great, thank you so much. Next up is Dr. Seth Brody with WakeMed Health and Hospitals. Dr. Brody?
Yeah, well, thank you again for having me. As you're hearing from others, I think the message is going to be pretty similar. We're having a very similar experience to what you just heard from our colleagues, and very similar to across the country. Our COVID, this Delta strain is highly contagious, as everyone has heard, right? It's a little different than before. It's leading to higher hospitalizations, and it's impacting healthier and younger patients. So that's one of the big differences that we're all seeing, and that has now led to our COVID numbers at WakeMed we've surpassed our January surge already. We're already past it. So that's kind of been our experience, and so leading to significant capacity issues. But as you've heard, the capacity issues are well beyond just the COVID surge. We have sicker patients coming in for all types of reasons: respiratory disease, heart disease, stroke, trauma, etc. It's really been they're sicker. A lot of, as you heard before, chronic disease states have been delayed. Care for those issues have been delayed. That leads to patients coming in with more their acute illness on top of their chronic illness, makes them sicker when they arrive, and then it leads to longer lengths of stay, right? So they end up staying in the hospital longer for the same things, right? For the same conditions. So we had a baseline, very high census. I think all the hospitals would say this before the surge. So then you take this surge and you place it on top of a very high census and pretty much at capacity prior to this surge. You can really just right there, just on that sheer volume, you can see how your capacity issues become really significant. And then this population requires the population of the positive COVID patients now, and particularly with Delta, they are very sick. We'll have as many as 10 to 12 patients a day transfer from our medical beds into our ICUs on certain days. And that's on top of the ED, the emergency department admissions. So the acuity, the level of care that takes, right? So that impacts your staff, who's just, as everyone has said, is just working so hard. They've been amazing. Our entire staff, physicians, to our APPs, our nurses, all staff has just been, I think everyone, I'll reiterate what everyone was saying, we cannot thank them enough. And we need more. It's the other theme you're hearing. We need more staff. That's one of the critical shortages. You add on the behavioral health and the mental health tsunami that's out there, as people call it, and how that impacts beds and the discharges that you were hearing about as well, and how it's hard to discharge people for many different reasons. It adds up to a significant capacity issue. Our patients then, they're getting into the ICU and they're having very long lengths of stay there as well. So your ICU beds are filling up. We keep expanding. We have expanded already. We've already gone into our surge spaces for ICU. So we're creative, as all systems are now. We have to create these new spaces for care. We've been doing that, and they're safe spaces, but they're not our normal spaces. So we keep expanding bed capacity, but then you do run into the staffing issue, right? We can create all kinds of new spaces, but we have to have the staff that's adequately trained, et cetera, that can take care of these really critically ill patients. So the two things, the capacity issue is not just space, it's staffing. They go hand in hand. Pediatrics, I'll mention one thing there too around children's. Our hospital is also filled up around the Children's Hospital, respiratory syncytial virus, RSV. We saw no cases in January. Winter is usually when you see it. There's the shift into the summer. We had 180 positive RSV cases just in August alone, going from 0 in January. And our COVID positive rate for those less than 18 has doubled compared to previously. With schools reopening, that's obviously concerning. So what have we been doing? Like I said, we've been creating new spaces wherever we can. We keep expanding our ICUs. Our wait times are very high despite that. We've created lots of beds in our emergency departments that hold patients, and patients get held for a long time. So they wait for beds. As you can imagine, as the hospital's full and you have long lengths of stay and you can't discharge folks, that backs up the whole pipeline, right? So it's hard to get people admitted. Even to be seen and treated and released is hard. So those wait times are long, just like you were hearing for the other systems. Again, I would repeat the plea: vaccination, wear your mask, and when you're seeking care, which we know people will, if you can avoid the emergency department, it's a good thing to do that. And again, urgent care, whether it be adult, pediatric, orthopedic urgent care, there's lots of urgent care options. You call your primary care office. Mental health community providers around mental health, and your primary care offices, et cetera. We're really trying to encourage folks to seek those options, and telemedicine and virtual care, by the way, which we all have available to folks. So I think that's really important for our community to help in that way. Try to seek that care first, and we can reassure them they'll be elevated to hospital care if need be, right? All of our folks do that, but really important to try those other options first. But I'd also like to thank the other healthcare systems. We've partnered throughout all of this a lot. There's been a lot of conversations between the healthcare systems and partnered in many, many ways throughout the entire pandemic. And it's been a very helpful thing to have all the different systems communicate well and partner where we need to partner.
Well, it's great to see that teamwork. I do have a quick question for you, because you mentioned patients with COVID-19 being part of this situation that you're seeing. How many COVID positive patients does WakeMed currently have? And out of those, how many would you say are unvaccinated?
Yeah, we're now approaching 200 across our system. We have that includes about 15 in our hospital at your home program as well. So we're trying to manage patients in their home where we take providers to them. So we're eclipsing 200 right now. Of those, right around 90, give or take a percent or so. But if you just look in general, about 90% of that number are unvaccinated. So the vast majority are still unvaccinated, and that sort of plays itself out in the ICUs, et cetera. So we're right around that 10% mark that are being admitted that are vaccinated. There are breakthrough cases, we know that, but the vaccine is incredibly protective still overall versus against hospitalization and real serious illness requiring the ICU, et cetera. So those are our numbers.
Great, thank you, Dr. Brody, for sharing that. Our next speaker is Dr. Micah Krempasky with WakeMed Behavioral Health. Dr. Krempasky?
Good morning. Thank you for having me. I think it might be somewhat unexpected to have the psychiatrist here talking on a news conference about COVID, but what we're seeing is unprecedented numbers of people with behavioral health needs in our communities. The most recent studies have shown that we have a 40% increase in the number of people who are experiencing symptoms of depression and anxiety as compared to pre-pandemic numbers. So what that means is people are suffering and they need care, and they're concerned about where they're getting care. We've also seen people be reluctant to receive care. When I think about people who need behavioral health care, I think about it on a spectrum. So there are some symptoms that you can take care of in the community. So going to your primary care doctor, talking to a therapist, going to a local urgent care, where you can really get help with the stress, maybe medications help treat depression. And we just want everyone to know that there are lots of resources available in the community to help. So don't avoid seeking care, because like the medical conditions that we've talked about today, the longer you delay in that, the worse the symptoms get, and it can progress. And then we get to a place where we're needing emergency care and things are much harder to treat. On the other end of the spectrum of mental illness is patients whose symptoms are so severe that they're not able to safely manage themselves in the community. People who have severe suicidal ideation, or people who are experiencing psychosis to a level that they're not able to safely and adequately care for themselves. Those people require emergency care, and they require inpatient level of care. So those people come to our emergency room, where behavioral health providers like myself start the stabilization process. We also treat medical conditions and make sure we really understand what's going on. And then we start the referral process for these people to seek care in inpatient psychiatric hospitals. So psychiatric care is a very specialized service that many acute care hospitals like WakeMed does not have that service. So we rely on inpatient psychiatric facilities, and we refer the people to those facilities to seek inpatient beds. The problem is we have a shortage of inpatient psychiatric beds across the state. And so the wait times for those inpatient beds can be very long, days and days. So patients are sitting in our emergency room who no longer have medical needs and don't have acute medical things that need to be addressed, but we can't get them to the psychiatric level of care that they need. So as we've heard about the capacity issues that we're facing, the acuity that's in our emergency room, and frankly, emergency rooms are a very difficult place to seek mental health care, because it can be a very loud, chaotic environment. And that doesn't always feel great when you're struggling with depression or other things that are happening. It becomes a really difficult situation for all that are involved. So as we think about what's going on with the mental health situation, we really are working together as hospital systems to advocate for the care, for us to use the resources that we do have wisely and efficiently. We're also partnering with our county, our state, and our federal agencies to help levy resources to help us manage the care. And we're all working together to make sure that every adult and every child that has healthcare needs, including behavioral healthcare needs, have access to care when they need it in a way that's really comfortable for that. So my takeaway messages here are: people are suffering, mental health is on the rise, or mental health issues are on the rise. And if you have those issues or know someone that does, please don't avoid seeking care. Seek it early. Know that there are resources available in the community. And if someone really is in danger or has life-threatening issues associated with mental illness, please do come to the emergency room. Don't avoid coming because you know what's going on, because we need to give you that level of care too. And we welcome everyone that comes in our door to give them the right level of care. And we're working really hard to make sure that the services that you need are available to you.
That's great. And for the average person who may be listening in today, how will they know what the tipping point is for them to seek help from the emergency department versus maybe behavioral health urgent care?
Yeah. So many, perhaps most, mental illness can really be taken care of outside of the hospital and maybe best taken care of. A quiet, calm, nurturing environment really is ideal for when you're seeking behavioral health care. So when the tipping points comes, when there is imminent dangerousness. So if someone is experiencing suicidal thoughts, that they really, you feel like they can't be safe, or experiencing thoughts of hurting others, or a level of psychosis, hearing things, seeing things, not thinking correctly in a way that they're not able to meet, keep themselves nourished, keep themselves safe, keep housing, all of those other things, then those are times that emergency care would be required.
Okay, thank you so much. Our final speaker this morning is Dr. Jose Cabañas with Wake County. He oversees our EMS department. Dr. Cabañas?
Thank you. Thank you all for being here, having this conversation with the community. First of all, I want to share that we value the partnership and the collaboration that we've had as an EMS system as Wake County with all of our healthcare partners and colleagues throughout this pandemic, last 18 months or so. Wake County EMS is also feeling stress of our strained healthcare system. When we transport a patient to the hospital, we need to transfer care to the team in the emergency department, and we just can't just leave the patient if no beds are available. And we have to wait for space to open up. So I want everybody to understand that everything is interconnected. And the longer we wait, less units may be available to respond to the next call. And with our call volume at the highest level in EMS history, the time delays can rapidly add up. I want to remind folks that we have a system in place to ensure that we're getting to the most serious calls first. We triage calls to ensure that our life-threatening emergency conditions are getting the resources rapidly when they need it. And if you need us, we will be there, but the system is stressed. There are more things as a community that we can do to improve the current situation. First, we need everybody who is able to get the COVID-19 vaccine, which will help prevent you from becoming seriously ill and being hospitalized due to the virus. We also want to urge our community to avoid the emergency department unless you have an emergency health need. Please consider, like our other colleagues just summarized here, if you have healthcare needs, getting early into your doctor's office, look at the telehealth options, urgent cares, other clinic options for those less serious medical issues. These actions will help relieve the pressure on EMTs and paramedics in our hospitals and make sure the people who need emergency care the most can receive it in a timely manner. Thank you.
And Dr. Cabañas, you mentioned record-setting EMS call volume. What kind of numbers are we talking about? And why do you think we're seeing such a historic increase in demand for services?
That's a great question. So just to give some context, for fourth month in a row now, Wake County EMS is running more than 10,000 calls in a month. So Wake EMS responded to 10,600 911 calls in July, and we're at a pace that we will actually break 11,000 calls in August, and we're averaging around 355 calls a day. We've had several days where we've had exceeded 400 calls in 24 hours. So in our view, the spike of demand for services in 911 is due to three things. And some of our colleagues here have summarized some of those points. But first, we know that members of our community put off medical care during the beginning and throughout the pandemic for all the reasons that we all have discussed before. certainly this healthcare system already had limited capacity, and now the delay in care that occurred throughout the beginning and different stages of the pandemic, now everybody's trying to access the healthcare system for all kinds of reasons at the same time. Second, the COVID surge clearly plays a critical role because we're having with this Delta variant, which is more contagious, we're having people sick requiring inpatient hospital or high level of care. And third, our county didn't stop growing in the background of the pandemic. The Wake County kept growing, so we have now more members of the community to serve. So I think all these things together have combined to feeling the stress and pressures we feel right now in the emergency services system in the community.
Great. Thanks, Dr. Cabañas. So at this time, we're going to take questions from the media. Again, to our reporter friends, type your name, the name of your media outlet, and your question in the chat box. I'll read them aloud as they come in. If there's any Spanish-speaking media on the call, Dr. Cabañas can respond in Spanish. Just let me know that you would like to see that in the chat as well. And we actually had a few come in as everyone was offering up their comments. The first one comes from Josh Zach. He asks, we've heard in the past that hospitals have had issues with staffing when hospitals reach or come close to capacity. With several of the key healthcare systems moving to require their staff get vaccinated, how would that add to strains on scheduling? For example, WakeMed will begin a vaccination requirement on November the 12th, and vaccination is a condition of employment. Are hospitals at risk of losing key frontline workers? Perhaps one of our physicians from one of the hospitals would like to respond.
I can respond on behalf of UNC. Our vaccine mandate date is September 21st, and we do know that there's a certain percentage of our coworkers who cannot get the vaccine due to medical reasons, and those coworkers are exempt. And typically those are probably coworkers that we don't have in areas treating COVID patients because of immune system issues. Then we have another cohort of coworkers or teammates who would like to claim a religious exemption, and those are being vetted at a system level committee. And if that exemption is denied, then it is a condition of employment for them to be vaccinated. It's the safest thing for our patients. It's, we feel, medically the safest thing for them and all of the individuals they work with. They at that point have the option to be vaccinated, or they resign from their position. And that does strain us when we're already working short. But like I said in my earlier comments, it would seem like the right thing to do for the broader community. We have tried to spend a lot of time educating about the specific vaccines and answering as many questions as possible. And we will know as we get closer to that date or whether we have resignations along those lines. That being said, every other healthcare system also has a vaccine mandate. Their date might be slightly different, but these are individuals who are probably contemplating leaving healthcare altogether. And that's sort of why we're short to begin with. There was burnout before the pandemic, and then just the stresses of taking care of patients under these abnormal conditions with high census, and we had visitation rules, we had PPE constraints earlier on. All of those have now subsided, but it's just the overwhelming exhaustion of taking care of all these really sick patients that people are just choosing to leave. And then you add in some people were leaving to be travelers because there was that demand, and if they were able to do that, they could make a lot more money as a traveler, but then they're working in a system that they don't know, and there's less familiarity. So we're doing everything we can to retain our staff, and we're looking to recruit and hire more. They do know when we interview them that the vaccine is a condition of employment.
Yeah, I would add, agree with all that was said. You know, the vaccine mandate is there to protect our patients, to protect our colleagues, protect each other, protect the community. And the scientific evidence for it is really solid and very good, right? It's excellent, right? So it is really hard to turn the other way. And it's mandating vaccines is not new, right? We have a flu vaccine mandate as well. It's been in existence for years now. We mandate vaccines all over the country and for children, et cetera. I mean, we all know that, right? So this isn't a new concept, really. It's just so important. It's a great question because, yes, that's one of the real downsides. We hope through education and answering questions and being open about the process and why we're doing it, we hope that keeps people. And we certainly have the same exemption process, et cetera, for all of those, you know, respecting all of those various issues. Same process. I think that's everywhere. But in the end, if you're left with some folks, it's one of those decisions you have to make that says for the better good, right, of everyone, that we have to make that choice. Other systems that have done this across the country, in the end, their numbers that leave are relatively small. But again, a good question, because when your staffing is short and you're struggling with that already, right, and keeping up your staff, you really don't want to lose any great frontline worker at all. And we hope they don't. We hope no one leaves. I hope no one leaves any healthcare system for that reason.
Great, thank you for those responses. And on the end of staffing, we have another question from Jason DeBrune with WUNC, the local NPR affiliate. He asks, we have heard about staffing shortages and burnout, especially among nurses. Can you address staffing levels, particularly among nurses at your hospitals? And some of that may dovetail with what you've already said. Is there anything you'd like to add to those comments? I think we've maybe captured it then.
It is what it is. I think we're all doing things to try and retain our staff. You can sometimes put people in non-traditional roles coming out, for instance, utilizing EMTs and paramedics to help with respiratory therapy. That's another area that's very short-staffed through this pandemic. I don't think North Carolina is even graduating enough respiratory therapists to meet the open positions that we have across our healthcare system. We're offering loan forgiveness for those who are new graduates. We're offering, contract bonuses for people to pick up extra shifts if they pick up extra shifts for a certain number of hours. We have a lot of work going into trying to make sure that we are supporting not just our nursing staff, but really all of our frontline caregivers. And, if we can get more people to choose healthcare, that's kind of where we need to go is further upstream in the education system. But that's not a quick fix. That doesn't help us for this pandemic. It will help us going forward. There's also a lot of workplace violence issues in healthcare that we're all trying to address as well with the behavioral health patients, the ones that are in our emergency department. They can be impulsive, they can strike out. Our dementia patients who also have behavioral issues, they're up on our floors. That's why the assisted living facilities can't take care of them and they bring them here. And so our staff are faced with this, and we have hired protective services individuals. I know that Duke, Raleigh, WakeMed are having the same challenges, and it's hard to recruit people to work in an environment where you have long days, you have very sick patients, you have families that sometimes can be belligerent, and then you have these individuals who are striking out, and they can't help it as part of their disorder, but it's not a real attractive place to want to come and work. People do it because they have a calling to help others, and that's why we all went into healthcare to begin with. But we need to address those other societal issues to really want to attract more people to come into nursing or any other healthcare profession.
And to add 2 points to that, the market for nurses, nurses can move around too. So even if they haven't, there's a lot of reasons why nurses and other staff have left healthcare for all those stressors that you just heard. It's some people are maybe we're going to retire regardless. They move towards that. There are childcare issues at home. There are all kinds of stressors that were mentioned. So that puts a big a pull from the nurses. Also, one thing, and it relates back to the vaccination question, we have folks out because they're COVID positive as well, right? So that impacts your staffing also. So, that's a big stressor on the system as well. At any time, you don't know how many you're going to have, right? And they can't be working. So that number has definitely increased with Delta as well. It's just hard for people to to avoid it completely. Doesn't mean they're getting it in the hospital, they're getting it all over like the rest of the community. But that's another stressor on top of it regarding staffing.
Definitely. We have a few more questions that have come in. The next one is from Lillian Donahue with CBS 17. She says, Dr. Brody mentioned that RSV is filling the Children's Hospital on top of an increase in COVID-19 patients. Why is RSV so prevalent now and was not so much in the winter? And could other illnesses like this in both the adult and pediatric populations continue to stress the healthcare system as we get closer to fall and winter?
Yes. The first part of that question on RSV, I wish I knew. I've been reading that. We're looking for those answers. I don't know that anyone knows for certain. Clearly, RSV is usually more of a winter illness, respiratory illness that leads to admissions commonly. That does happen, although most people with RSV do not get hospitalized, or even including children. But that is something we've always seen. Something has clearly happened here related to this pandemic that has shifted it. Probably, and there's theories about kids being out and about now again, where they were cooped up, right, for all this time, wearing masks, and then we released and everyone's out, and now RSV is spreading. That's sort of the simplest and most direct explanation of why now. But there could be other reasons that I don't know that I can explain. That's probably the most straightforward one. Not going to guess beyond that. As far as what's coming this fall, that is very concerning. We were fortunate, which is interesting, probably because everyone was wearing masks, or so many people were wearing masks. We had a very, very low, we had an incredibly low flu rate. We had almost no admissions from flu. It was incredibly low. But our usual year, we peak, right? In late fall, winter, and we fill up the hospital at that time of year regardless, without COVID, without a pandemic, with flu. So as far as flu and RSV and all that happening, we are definitely concerned that on top of all the things we've been discussing here, that we'll have flu patients on top of that as well. So that is very concerning, both for adult and pediatrics and children's. We're worrying about both. We had a time recently from RSV where our PICU was full with patients. It fluctuates, but if we're already there in the summer, we're definitely worried about what's coming.
Well, and our next question has more to do with RSV, so I'm going to read it next. It's Patrick Thomas with Spectrum News, and he says, I interviewed a mother last night whose child recently battled a case of RSV, was hospitalized, and is now recovering. She said she saw up close what hospital overflow due to COVID-19 is like at WakeMed. She says nurses and staff were doing all they can, but it is worrisome when you don't know what's going to happen next. What would you say to parents? What should you say for parents to expect when they bring their child through the hospital doors with RSV?
Yeah. Well, first things first. Yes, I feel bad. We all feel badly that folks are waiting for care, right? And waiting for a bed. It doesn't mean they're not receiving any care, right? Because they come in through our children's ED emergency department and they're being seen and care is initiated, but they're often waiting then. That's not no care. That is waiting for the next level of care in the hospital, into a hospital bed, et cetera. So they're still providing care. So the first thing we do in those scenarios when they're waiting is we are providing that care in an emergency department. The negative of that is it's not the ultimate, and it just creates more of that, right? It creates a backup in that emergency department. You can't see other people. There's longer waits in the waiting room, et cetera. So those patients holding like that are getting care, but it creates other issues. We have the staffing. It is a constant stress though on that to keep that level of care there, and we have it, and we're doing it, and we're finding folks, and it's a constant daily effort. So when they do get admitted, as she said, the folks are working really hard, and that's noticeable to patients. And I think this is true everywhere. They're working hard, and they're working hard to maintain that level of care. So I would reassure them they're still getting the top level of care and best care, but there are times when you're waiting for certain services. There's no doubt about it. We try to triage that, so the most critical services are always provided, and then you do the things that can wait. Those are the things we allow to wait.
Yeah, I'd also add that I know I'm not the only emergency department who is working towards having a system where there are providers in triage. And oftentimes, even though it may not be completely obvious to everyone, you are getting seen by providers, you are getting cared for from the moment you enter triage. There are nurses and other techs in our lobbies. Lab work and x-rays are getting done while you're waiting in our lobbies. This is sort of, I think, also a national trend as well to deal with surges. But I would just offer that out to folks who are wondering or sitting in a waiting room somewhere wondering what's happened. And people are looking at you and looking at your labs and looking at your x-rays, and the nurses in the lobby are watching and repeating vital signs and making sure that everybody who needs a higher level care is getting to that higher level of care.
Great, well said. We have about 6 or 7 questions left, so I'm going to cut off the entering of any more questions into the chat to make sure that we, 1, get to all the questions that have already been asked, and 2, we get these doctors back into their emergency departments because, as you've heard, there are great needs there and they have to go to work. But I do commit to getting back to everyone who has already asked a question. So let's get right to it. Brian Anderson says, for any of the folks on the panel, if someone goes to the hospital for something besides COVID-19, how often are they in the waiting room, and how likely are they to become infected as a result of their presence in the hospital? In other words, how concerned should someone be that they will get COVID if they choose to go to the hospital?
That's why we instituted that all patients and all visitors need to wear a mask upon entry. And, we test every one of our admitted patients. So before they end up in a bed in our hospital, we know what their COVID status is. But we will test immediately based on symptoms. But the masks really, just as they protect you in the community, they protect you in a waiting room. We also don't allow visitors to stay in our waiting room so that we can continue to physically distance our patients so that they have enough space and they have their mask on, and that will protect them while they're going through and they're being seen. We do cohort all of our COVID-19 patients into particular ICUs and on certain floors behind double doors, more for staff awareness so that they will wear their personal protective equipment, but they all have doors shut, and we have really good air exchange in the hospital with HEPA filtration and scrubbers. So you should go if you have an issue that requires our ED and know that you'll be placed appropriately so that you will not have a risk of getting COVID. I really think the hospitals are a safer place than going out in the community if people aren't wearing masks. So you should be reassured you will safely be treated and you will not pick up COVID while you're here.
Great, thank you. Our next question is for Dr. Cabañas. It comes from Richard Stradling with the News and Observer. He wants to know, what would a normal monthly number of EMS calls have been before the pandemic?
That's a great question. So just for context, 2020, when the sort of initial part of pandemic and sort of the initial stay at home and all those orders, everybody's sort of volume sort of completely sort of dropped. So, but when you look back to a kind of a 2019 better baseline, you will see, just to give you some context, similar time frame this year, we were averaging around closer to 300 or so calls a day, and we're now around 357 calls a day in average. And then there's days that we've had 400. So I give you a little bit of a context of that difference. Clearly, the experience that we're seeing in the community with over 10,000 calls a month is a complete new thing for us, that we've never had that threshold before. We've had prior months of 9,200 calls a month or those kind of things, but in pace to 11,000 calls in August, it's concerning the rapid increase in demand. We all know in our healthcare systems and EMS that there's always a natural annual growth rate, but this experience is just very rapid compared. It's not our normal rate of growth that we are accustomed to in healthcare.
Thank you so much. Our next couple of questions are from Aaron Thomas from WRAL. His first question is, how much of the lack of available beds is the increase in patients from COVID, and how much is low staffing levels?
I would say for us at WakeMed currently, it's not due to staffing. We've been able to, even though that's an incredible stressor, we've been able to accommodate that thus far. So, and we've expanded beds. So that tells you the stressors that puts on your staff, what I just said, right? We've expanded our capacity all over and then stretched our staff. That is lower than previously, as others have said, right? To still cover all of those patients. There's only a point though that you can stretch that rubber band, right? I mean, it's so that's where it gets tougher as the numbers keep going up, and the strain of the COVID surge on top of that, and you have to keep creating all of these new spaces and the level of care, as we keep saying, right? It's very labor intensive. That's one of the differences where a nurse may be able to manage different medical conditions that they've dealt with for years and years and years, right? And know how to do it, and it's less sort of labor intensive. These patients require a lot of care. Just the donning and doffing and putting on all your equipment, your protective equipment takes time. Proning patients, one of the really common things we do when they require oxygen, et cetera, really takes time. It's not your normal level of care. Even out of the ICU, it's not your normal level of care. So that's the stressor. We're sort of at that point where, again, it's the staffing concerns you, because as the numbers keep rising, which they currently are, you start to see where that just stretches more and more. So that's where we are currently. I think everyone might be in probably a similar situation, but it differs, depending on what unit you're talking about, et cetera. It gets down to that sort of that level of detail. And you have to have the right people to cover the right things. You can't just say, oh, I've just found 20 more nurses in the ambulatory practices, right? In primary care, and we're just going to move them in the hospital and we're good. We have 20 more nurses. That's not how it works, right? A lot of them haven't been in a hospital in a while, so you have to train them, and then you have to put them in the right place, right, for the right level of care. So it's a complex puzzle.
I agree 100% with what Dr. Brody said. We're in the same situation. We've continued to keep our beds open. We have not closed any beds, even though we are challenged on the staffing front.
And I think that kind of goes to his next question, which is, how is the capacity for your hospital now versus where you would like to keep it?
Well, where we'd like to keep it, that's sort of a loaded question. I think that was a harder to answer. But what I'll say is I mean, all of our hospitals in the area, it sounds like we were full before this happened, right? We're all the reasons we said. So, and that was already a bit of a stress. So where I would say where we'd like to keep it, your goal would be, could you easily create surge spaces and stuff like that where it's safe and you can provide the best care for all of the additional patients, and you could continue the care that you did. That's your ultimate goal. You could continue to take care of the community for their chronic diseases, their acute diseases that are non-COVID, right? Not impact that at all, and then create surge spaces and be able to keep expanding beds to accommodate every single COVID patient. That's your ultimate goal, right? I mean, that's what you want to do. And that's what we try to do. But what happens is, as you create more and more of these surge spaces, which we have no choice, we are, you then have to think about shrinking down those other services, right? You have to start to think about, how do we do that? That's when your operating rooms are impacted. What kind of cases can come through? And that's why we don't talk about elective versus non-elective surgery. We talk about its time sensitivity, right? You don't want to delay a surgery that needs to be done in 3 or 4 days because of COVID. You can delay surgeries that can wait a month or 2 months or et cetera, right? It's more about timing of the surgery. Most surgery is not, quote, elective. It's a bad term, really, right? It's a semantics, but it's not a good term. So it's really about time sensitivity. When does it need to be done? If someone has a cancer diagnosis, could you wait another week? Sure. But how many of you would want a family member to wait months for cancer surgery? I think the answer is you wouldn't, right? So that's time sensitive. It doesn't need to happen tomorrow, probably not, but you don't want to wait a month either. So those decisions are hard. So there's always that sort of pull, and those patients, do they end up in the hospital? Do they not? Those kind of things. So it's a complex puzzle to try to put together for everybody. And when you pull on one lever, it affects the other almost always. So it's like I said, it's about surge capacity and then maintaining the care of the community otherwise. And that's our goal.
Absolutely.
Another way to look at this, just from a different perspective, is all of the hospitals are used to surging. We do it every flu season. And typically you surge for 3 or 4 months, and then summer, it gets better. Our staff gets vacation. Our volumes drop. Our physicians can take vacation with their families. And then you kind of recharge for the next surge, which happens again during the flu season. That just didn't happen. And so we've had an 18-month-long flu season going into a worse flu season. And I think that's really where we are. We want to go back to the previous life where we have a 14-month surge. We're used to doing it. It's always been that way, and not have this perpetual need to stretch and take more and more and more patients. So that's a different way to look at it, although Dr. Brody described our lives right now perfectly and where we wished we would be, but that's just not our reality this year.
Great points. Our almost last question comes from Andrea Blanford with ABC 11. She says, among those hospitalized with COVID, who are they? Dr. Brody, specifically, can you elaborate beyond just vaccinated and unvaccinated? Are these young people who are generally healthy and athletic? Are these people with comorbidities or other diseases such as obesity and diabetes? And what would your message be to people about maintaining overall healthy lifestyles right now?
Yeah, that's a good question. There's been a shift in the demographics of those who are hospitalized with COVID for sure during Delta. It has, as I said earlier, it has definitely impacted younger and healthier patients. One of the comments I hear from our ICU doctors it's really stressing folks from the emotional component of taking care of people is they'll say these are people that should only be in the hospital because they fell off a skateboard. That's one of the comments that always strikes me, right? You do not expect them to be in there and then being intubated for COVID. This is not, so they do not have a lot of comorbidities. Of course, we have people that do, right? If you're immunocompromised and you do have a lot of comorbidities, we have plenty of patients like that. In the first round of this, the first surge, we saw a lot of that. More of the elderly, more of the with lots of comorbidities, et cetera. But a lot of that population got vaccinated, especially over 65. We did a good job in this community across the board, getting the elderly and those folks in nursing homes, et cetera, vaccinated. So it made a big difference. Delta, as you've heard all across the country, I think our average age is almost 20 years younger than it was in the first surge. So much younger, not as many comorbidities. Of course, people have them, but we're seeing people without them. That is almost, then the vaccination is the other big one. And then we'll see comorbidities. We will see those who are vaccinated. I think the rate of them having comorbidities is a little bit higher as a percent. So it speaks again to the protection of vaccination. If you're healthy and vaccinated, your chance of being hospitalized is reduced 25 to 30 fold, basically. It's way, way down. So those who've gotten very sick and are vaccinated, we are seeing almost all of those have significant comorbidities. So that's where I'd say that, but we're seeing pretty healthy, relatively healthy people who are younger, and unvaccinated, et cetera. We saw big demographic shifts earlier too around the social determinants of health in different parts of our community, including race, et cetera. That's still there to a degree. Different vulnerable communities still seem to be admitted at a higher rate than you'd expect, but that also reflects access to vaccination, et cetera, as it always has. So that's still there too to some degree.
Great. Well, this is our final question for everyone. It's from Chad Flowers with WRAL. He asks, how would you describe the overall condition of hospital health right now? Would you say it's critical, stable? How would you describe it?
Interesting question. I would say critical but stable. Why am I saying that? I guess more important than the words. It's critical because we're at, when you're creating new spaces, including converting lobbies into hospital areas, right? That's critical. Are we able to? And I'm saying stable because we're able to do it and we're doing our jobs and we're taking care of people. So it's stable in that degree, but it's critical. It's critical from a staffing perspective. We're doing our jobs, we're taking care of everyone, but how far can you stretch? And are we at a critical levels with staffing? Yes. I think all of us would share in that. So that would be my answer. I'd say critical, but we're stable in that we're still marching forward and we're still doing everyone's doing their jobs to the highest level they can.
I agree with Dr. Brody that it's critical for all the reasons that we've talked about during this press conference. And I think since we have not yet reached our projected peak, I know that at WakeMed, they've already exceeded kind of where they were last surge, and we're predicted to exceed our peak as well. I would say it's guarded. We tend not to be as reactionary, and people in healthcare stay calm. We go through codes, and Dr. Plonk is in the ED, and it's got a lot of chaos around him, and he stays calm. So I think that's why the public is not understanding how critical it is right now. And again, I would just use this opportunity to say, please get vaccinated so that you do not end up a patient in one of our hospitals. We don't want your business. We want you to be healthy. That would be kind of what I would say.
Great. Well, thank you to our media who have participated in today's news conference. Thank you to all of our amazing physicians who have been on this call this morning. We appreciate everything that you are doing in this challenging time to keep our community members safe. So thank you so much for that. And as everyone has been saying, if you have not gotten your vaccine yet, or you haven't gotten fully vaccinated yet, we can help you with that easily at Wake County. Just go to our website, wakegov.com/vaccine, and we have places all across the county where you can get a free shot. So thank you everybody for joining us today, and this will conclude our news conference.